It is such an honor for me to be invited to present at the fourth Congress of the Arab Thyroid Association. And I thank President Al-Jahani so much for this invitation to attend the meeting. I'm Lori Wirth from Massachusetts General Hospital in Boston. I wish I was there in person with you, but unfortunately I'm not. But I will be talking about optimizing systemic therapy in iodine refractory advanced differentiated thyroid cancer. Here are my disclosures. And I thought I would start out by setting the scene. You know, radioiodine refractory differentiated thyroid cancer is not just one disease. This is really a spectrum of different diagnoses and different histologies. If we think, for example, just about papillary thyroid cancer, here you can see there are 9 different subtypes of just papillary thyroid cancer, according to the new WHO criteria. So there is really a broad spectrum of disease. Now, it is important to be sure that when we are taking care of patients with iodine refractory disease, that they are indeed refractory to radioactive iodine. And I just included here in this slide, I won't go into the details, the definitions of the American Thyroid Association guidelines for iodine refractory differentiated thyroid cancer. The Martinique principles on radioiodine refractory disease are a little bit more subtle and refined, although I think that there's more in common than in difference. But it is important to recognize when our patients do have iodine refractory disease, and when they do, there's no benefit from further radioiodine treatment. In fact, there is potential harm because there is a risk of secondary cancers, including leukemia, when patients get more and more radioactive iodine. And on the other hand, when patients have iodine-sensitive disease, that's probably the best therapy for them when they need systemic therapy. So I will be focusing on iodine refractory differentiated thyroid cancer. And it really is, there is really a wide natural history. And we can see that from recent data from the RIFTOS trial, which was an observational study taking a look at patients with iodine refractory disease. And there were 2 cohorts. The second cohort of patients were enrolled in observation, but they weren't started on a multi-kinase therapy right away. They were followed, and we took a look at what is the median time to develop symptoms, to develop disease progression, and even overall survival. And what we found was that the median progression-free survival in this patient population is 14 months, but the median time to symptoms is not until 51 months. And after follow-up, we still didn't meet the median overall survival. However, the 3-year survival rate was 78%. And so I think about this in terms of these patients really fall along a bell-shaped distribution where the median overall survival might be around 7 years for this patient population. However, there will be people who will have rapidly progressive disease and won't survive for even a year. There will be people who will survive for even more than a decade. So it's really important to think about this when we're in the room with an individual patient, because when we're just meeting those patients, we don't know where along that bell-shaped distribution their disease will fall. Now, of course, so I'm giving this talk from the U.S. perspective because that's all I know. But in the U.S., of course, we do have 2 approved first-line multi-kinase inhibitors for iodine refractory disease, namely sorafenib and lenvatinib. In the U.S., now it is felt that for most patients, lenvatinib is the preferred therapy because the progression-free survival benefit compared to placebo in the SELECT trial was longer than it was with sorafenib compared to placebo in the DECISION trial. The objective response rates are a lot higher with lenvatinib compared to sorafenib, and so lenvatinib is considered to be the preferred first-line therapy. And here is a schema for the SELECT study design. I think the audience is probably pretty familiar with this, but basically patients with progressive iodine refractory differentiated thyroid cancer were enrolled in the SELECT trial and randomized in a 2-to-1 fashion to lenvatinib versus placebo. And when patients were found to have disease progression, they were unblinded, and those that were on the placebo arm were then offered crossover to receive open label lenvatinib. And the primary endpoint of the trial was progression-free survival. And I already showed these top-line results. There was a significant improvement in progression-free survival of 14 months over placebo with an objective response rate of 65%. So it was based on the SELECT results that led to lenvatinib garnering healthcare authority approvals around the world for iodine refractory progressive differentiated thyroid cancer. Now, it's not a free ride on therapy. Adverse events that are related to lenvatinib are fairly common and have to be managed. You can see here in this table that adverse events are seen frequently: hypertension, diarrhea, fatigue, etc. The grade 3, 4 adverse events are a lot less common, however, but we need to be aware, particularly on how to manage hypertension optimally, how to manage diarrhea optimally, etc. These adverse events can be managed by dose holds, dose reductions, and good supportive care. But in SELECT, the adverse events did lead to permanent discontinuation in 14% of patients. So I think what happened following the decision trial with sorafenib, what we saw was a drug that causes a moderate amount of adverse events, yet relatively modest toxicity. So I think that what happened in the field was that the pendulum swung away from starting a multikinase inhibitor as soon as possible in these patients and instead holding off as long as possible because of the adverse event profile. And these drugs don't cure patients' metastatic disease. But is that the right tack to take in patients with iodine refractory differentiated thyroid cancer, especially if we have a drug like lenvatinib that really does seem to work better than sorafenib, though we don't have a head-to-head comparison? So are there data to guide this? There have recently been several retrospective analyses of correlates of efficacy from the SELECT trial that I want to share with you that I think address this point nicely. I'm not going to show all of those data in the interest of time, but let me show you the data taking a look at patients based on their ECOG performance status, and then also all of the patients in SELECT who had lung metastases, because I think that these data get at that important question of what is the best time to initiate therapy. So with ECOG performance status, we did an analysis taking a look at all of the patients that were randomized initially to receive lenvatinib, and then took a look at how do the patients do if they had an ECOG performance status of 0 versus an ECOG performance status of 1, which is in the Kaplan-Meier curves here in pink. The ECOG performance status of 0 is in blue. And what you can see is that you might expect that people with a worse performance status might not survive as long, and we did see that in terms of overall survival. But they should still have the same benefit from therapy if all else is equal. Yet if you look at those PFS curves, you can see that the people who had an ECOG performance status of 0 had a better PFS benefit compared to those who had an ECOG performance status of 1. And so we can surmise that what that means is that because of the enrollment criteria to get onto the clinical trial, apart from the patient's thyroid cancers, they needed to be in pretty good health. So they couldn't have heart disease, kidney disease, liver disease. So if they have an ECOG performance status of 1, it's probably because they were symptomatic related to their thyroid cancer. And so if you wait that long to initiate lenvatinib therapy, the PFS benefit isn't as good as if you start therapy before patients have symptoms from their thyroid cancer. And we also saw that when we looked at objective response rate, and you can see here in blue, the patients with an ECOG performance status of 0 actually have better responses. The response rates are higher and the responses are deeper compared to what you see when the ECOG performance status is 1. So to me, the take-home message from this analysis is that the lenvatinib efficacy is greater in patients with less advanced disease at the time of initiation. Now, what about lung metastases? So let me show you the data from that analysis as well. What we did was we took a look at overall survival and progression-free survival in all of the patients enrolled in SELECT, randomized to either lenvatinib or placebo, who had lung metastases of 1 centimeter in size or longer. And so what we found was that, the progression-free survival benefit with lenvatinib compared to placebo in patients with lung mets is very good. It's even a little bit better than what we saw for the overall trial. That's not unexpected. But I think what was a surprise was that there actually is in this patient population an overall survival benefit, even though most of the patients who were initially randomized to the placebo arm did cross over and receive open label lenvatinib at the time that they experienced disease progression. So 89% of the placebo patients in this analysis crossed over and received lenvatinib, and that was at a median of just 4 months by the time of crossover, which is the median progression-free survival in the placebo arm. So again, the take-home message to me is that if we start lenvatinib, even when patients have lung mets as small as 1 centimeter in size, when they've had iodine refractory progressive differentiated thyroid cancer, if we start earlier rather than later, there's actually a potential for better overall survival. So to me, what these data mean is that I think that if efficacy is the most important thing to our patients, then we need to think about that pendulum swinging back to earlier initiation of therapy when patients have progressive iodine refractory DTC. We definitely don't want to wait until they have symptoms. We don't want to give them treatment when they don't need treatment at all, but holding off as long as possible probably isn't doing patients any good when it comes to efficacy. Now, I think that we really need to do this with shared decision-making with the patients, taking the patient's values and preferences into account, as well as our provider expertise and these data, because some patients will certainly prioritize living as long as possible. Other patients, however, prioritize quality of life and may want to postpone initiating lenvatinib to avoid any impact on their quality of life. And that's something to consider. And we really need to discuss this with the individual patients, unless, of course, the patients have a very large tumor burden or are symptomatic or have rapidly progressive disease. Then we don't want to delay the initiation of therapy. Now, another tricky question is, what is the preferred lenvatinib starting dose for these patients? Because of the side effect profile, the FDA mandated that AZI carry out study 211, which randomized patients to a starting dose of 24 milligrams of lenvatinib, the FDA-approved starting dose, versus a lower dose of 18 milligrams a day. And this was a non-inferiority study with the primary endpoints being two co-primary endpoints: objective response rate at 24 weeks and grade 3 or higher treatment emergent adverse events also at week 24. And what we saw from study 211 was that the objective response rate at 24 weeks was not non-inferior with the 18 milligram lower starting dose. So you can see here that the objective response rate was 57% with lenvatinib 24 milligrams versus 40% with the 18 milligram dose. This was not non-inferior. So that primary endpoint did not pan out. And then when we took a look at the adverse events, you can see that there actually wasn't a difference that was statistically significant between the adverse events at 24 weeks with the lower dose versus the standard starting dose of 24 milligrams a day. The safety profiles were similar between the two arms. And so study 211 showed us that 24 milligrams of lenvatinib daily remains the best starting dose in terms of both efficacy and safety for most patients starting lenvatinib who have iodine refractory DTC. So now there are a wide variety of histologies. I won't show you these data, but when we took a look at subset analyses, patients with papillary thyroid cancer, follicular thyroid cancer, oncocytic, even high-grade differentiated thyroid cancer are approached similarly and do have similar efficacy with lenvatinib compared to placebo in the SELECT trial. However, there is an important exception to that, and that I think is when patients have, when their cancers harbor actionable genomic alterations. So these data are from a national database I just recently published from Japan, where 552 patients' tumors were evaluated. And what the group found was that potentially actionable, targetable alterations were found in a majority of patients with advanced thyroid cancer. So 63% of patients had hits. So BRAF V600E mutations were the most common, of course. RAS mutations were fairly common as well. But there were patients that were found to have RET fusions, NTRK fusions, and even one patient was found to harbor an actionable ALK fusion. So let me talk for a few minutes about gene-specific therapy for advanced thyroid cancer. And particularly, I'm going to focus just on differentiated thyroid cancer. Of course, now in our arsenal, we have RET-specific drugs that are FDA approved. We have TRK-specific drugs that are FDA approved as well. And now in the US, there was a recent tissue agnostic approval for dabrafenib plus trametinib in BRAF mutated solid tumors that don't have an acceptable treatment alternative. So importantly, when we look at the gene-specific therapy in this subset of patients with advanced iodine refractory DTC, we see really good efficacy. So again, in the interest of time, I'm not going to show you all of the data from all of these trials, but this table here summarizes at a high level the outcomes. So from the larotrectinib trial, in patients with NTRK1 or NTRK3 fusion positive papillary thyroid cancer, the objective response rate was 86%. And despite almost 4 years of follow-up, the median progression-free survival has not yet been reached. And only 2% of patients had to have discontinuation because of treatment-related toxicity. Larotrectinib is generally very well tolerated with mild neurotoxicity only. Now, unfortunately, patients with anaplastic thyroid cancer didn't do quite so well with larotrectinib. We still need to figure out how to leverage the NTRK fusions in patients with anaplastic thyroid cancer. And in the selpercatinib trial in patients with PTC who harbored RET fusions, when they had had a prior MKI therapy, the objective response rate was 85% and the median PFS was 27 months. This is very good for second-line therapy. But when patients hadn't had a prior multikinase inhibitor, we saw even better efficacy with a 96% objective response rate. And now at almost 4 months of a median progression-free survival, we still haven't reached the median progression-free survival time with selpercatinib and RET fusion positive PTC. So if patients have these oncogenic kinase fusions, I think that we want to turn to gene-specific therapy for first-line therapy when we can, because these drugs work so well and are so well tolerated. The same is true for ALK fusions, though we don't have the same level of data. We really just have case reports, particularly with alectinib showing very good activity in the few case reports that have been published. Now, what about BRAF V600E? So there was a trial in the second-line setting done that was sponsored by NCCN in the US, taking a look at dabrafenib plus or minus trametinib. We found, however, that the objective response rates were 35% with the dabrafenib alone, or 30% with dabrafenib and trametinib in combination, with median PFS of 11 months and 15 months. Not quite as good as what we saw with lenvatinib in these patients. So probably we don't want to be thinking about dabrafenib and trametinib in the first-line setting for BRAF mutated differentiated thyroid cancer at this point. However, we do have a very important randomized phase 3 international trial looking at dabrafenib and trametinib compared to placebo in the second-line setting in patients with BRAF mutated disease. This trial is going to be reported soon. Unfortunately, it was difficult to enroll too many patients in the US in the trial because of that FDA tissue agnostic approval that I mentioned, but there was very robust enrollment in the study in Asia and other parts of the world as well. So I look forward to seeing those data soon. If there is a BRAF mutation in patients, does lenvatinib work? We actually have good data to answer that question. From the SELECT trial, you can see here when patients did have BRAF mutated papillary thyroid cancer, the forest plot shows that there's a significant improvement compared to with lenvatinib compared to placebo. And then we also have data from a real world study that was done in the US where 89 of 376 patients harbored BRAF mutated papillary thyroid cancer. Those patients had a 76% objective response rate. And you can see here that their median PFS was really quite good in the blue line there. So lenvatinib is, I think, highly active in the first line setting. So I feel quite comfortable using lenvatinib in patients with BRAF mutated iodine refractory DTC in the first line setting. Now, here's a quick treatment algorithm for patients with iodine refractory DTC that we've developed at Mass General. When we are thinking that patients are going to need systemic therapy, then we do NGS testing of the tumor. We don't do liquid biopsies such as Guardant ctDNA testing because those tend to be non-informative in patients with thyroid cancer. However, if we don't anticipate that patients are going to need systemic therapy in the foreseeable future, we don't do the NGS testing in the interest of not spending those resources on information that we're not going to need for the particular patient. Now, if a patient on NGS testing has a RET fusion or an NTRK fusion, then we certainly consider gene-specific therapy. And I think that because these drugs are so highly effective and they're well tolerated, we don't think about delaying these therapies, particularly as long as possible. We really do think about earlier initiation of a drug like larotrectinib or selpercatinib in that patient population. When patients on gene-specific therapy do experience disease progression, you really want to do a biopsy of a progressing lesion if you can, looking for mechanisms of acquired resistance. So NGS testing of a progressing lesion is important to try to figure out why that tumor is progressing. It's a tricky problem worthy of a whole nother presentation, so I won't go into greater detail, unfortunately. But I think that's something that we're really still trying to figure out, and we really need to be enrolling those patients in clinical trials as much as possible. Now, when we don't find an actionable oncogenic kinase fusion in patients with iodine refractory DTC, I think we've got good good data that indicates that lenvatinib in general is the best first-line therapy for those patients. And we want to be thinking about for the patients with relatively slowly progressive, low volume asymptomatic disease, doing shared decision making with the patient to figure out the best timing of initiating therapy. When patients do have disease progression, if they have BRAF mutated disease, then dabrafenib and trametinib is a very good second-line alternative. If a BRAF V600E mutation is not present, then we've got good data that I didn't have time to show you on cabozantinib as a good second-line therapy for that patient population. So let me just wrap up and summarize the major points. A majority of our patients with advanced thyroid cancers will harbor a potentially targetable gene alteration driving their cancer. We really want to think about patients with advanced thyroid cancer as a paradigm in precision oncology. So I think that molecular diagnostics are critical for all patients with advanced thyroid cancer who will need treatment in the foreseeable future. And we want to make sure that the NGS assay that we're using is a very robust assay at detecting the kinase fusions because they're a little bit tricky and not every assay is as good as the next assay. And we want to do this testing whenever possible prior to initiating first-line therapy because gene-selected first-line therapy is preferable if there's an oncogenic kinase fusion that's identified. However, for most patients with iodine refractory progressive DTC, lenvatinib is going to be the preferred first-line therapy. And generally, the preferred starting dose is 24 milligrams once a day. Now, we do have big questions in the field. We really need to figure out how to leverage immunotherapy in patients for advanced thyroid cancer. It works really well in other solid tumors, but we haven't figured out how to use immunotherapy in patients with iodine refractory DTC yet. Um, and then what is the best sequence of gene-specific therapies and multi-kinase inhibitors? Can we use a drug like selpercatinib in a RET fusion-positive thyroid cancer? And then if we see disease progression, will those patients respond to lenvatinib? We need data. We really don't know the answer to that question yet. And then lastly, treatment earlier in the disease process may be better for a number of patients, including, I think we need to think about, should we be utilizing these highly effective drugs if patients present with very bulky disease in the neoadjuvant setting, or even in the adjuvant setting, such as when patients have RET fusion positive thyroid cancer and are getting treatment in the adjuvant setting with radioiodine. Can we get radioiodine to work better in a redifferentiation strategy? Those are really exploratory questions for the future, hopefully for future clinical trials. And with that, I will wrap up and say thank you very much.